We've discussed a lot of philosophical issues from amongst my eminent predecessors, but I'll do my best to develop the debate on when and when we should not use both antibiotics and antimicrobials, because I think what we haven't distinguished particularly in the session so far is the difference between antibiotics and other antimicrobials. I have a few disclosures which I list here, and I guess it's a bit silly showing you a slide like this to a group of expert wound healing clinicians, but I think it's just important to remind ourselves that the skin is a very important organ in the body. It carries out a lot of very important functions, and if that organ is damaged, then we can run into all sorts of health issues. So I think we're all talking at the same level there in terms of the importance of the skin and maintaining its integrity. And the problems that, as I see them, are this, that skin infection, breaks in the skin are very common because that's most of your business is dealing with breaks in the skin. And superficial skin infection, even deep skin infection, is very common. One of the most common reasons for giving antibiotics or indeed antimicrobials at all. We've already heard how it's difficult to distinguish between colonization and infection. Any break in the skin is going to get bacteria colonizing that lesion, and at what point do we change from mild colonization to infection? That's a difficult decision, as we've discussed. Is reducing bacterial colonization helpful in skin healing? I think we're probably generally of the opinion that yes, heavy bacterial bioburdens are not good for wound healing, but equally, I think we've also heard that sterility in wounds is not necessarily the best environment either for wound healing. There is, against all of that, there is a massive global health problem with antimicrobial resistance. So the more we use antibiotics, the more we're going to select out resistance. Should we use oral or topical agents, and if so, which one? Those are some of the things I'm going to try and cover. Now, we give different clinical names to infections at different layers in the skin and soft tissue, and by and large, the deeper you get the infection in skin and soft tissue, the more severe that infection tends to be, although that's not always the case. If one's going to use topical antimicrobials, they're clearly only going to be effective at the most superficial level, at the stratum corneum and possibly the epidermis. Anything in the upper dermis and below, you're going to be pushed to treat with topical antimicrobials. We've said already that any breaks in the skin get rapidly colonized, and unfortunately in the healthcare system today, particularly around the world, resistant organisms are increasingly commonly the organisms that colonize breaks in the skin. In a big study, well, this represents data from several studies going back over about 15 years, looking at the causes of skin and soft tissue infection. The predominant organism is always Staph aureus, with, depending on your local epidemiology, MRSA, so resistant organisms as well. You'll see a big blip in the E. coli, the green bar here. That's a false blip because that actually represents all gram-negatives, and gram-negatives do get isolated in skin and soft tissue infection, but usually in quite specific clinical scenarios like surgical site infections and of course some of the chronic wounds that we've been discussing in this session. So Staph aureus is the predominant organism. Beta hemolytic streptococci are rather underrepresented in these studies because they're harder to isolate, because they're often beneath intact skin, and so unless they're isolated from blood cultures, don't tend to get picked up in either biopsies or superficial swabs. If we look at the problems with resistance around the world, our previous chairman, Finn, was saying that we have a 50% rate in the UK. Well, that isn't the case anymore. We've actually managed to reduce it by good antimicrobial stewardship and good infection prevention measures. So antimicrobial stewardship and good infection prevention, as Dilip pointed out in his talk, works in terms of reducing the overall percentage of resistant organisms. But MRSA is a problem in terms of prevalence and causing skin and soft tissue infection is a massive global health problem. In the Americas, in Southeast Asia, you can see the Middle East is entirely missing from this slide, because one of the key issues with measuring resistance is good surveillance, and in many parts of the world, good surveillance just does not exist. And if we think this is a problem, these of course are gram-positives, an even bigger problem is coming our way with gram-negatives, because we have fewer antibiotics to treat those when they occur. Now, the reason I think we improved the system, improved our prevalence rates in the UK, was initially because of what we thought at the time were over-exaggerated press reports. But what these press headlines resulted in was the Department of Health, the government, getting very, very nervous about antibiotic resistance. And the government then decided to do something about it. And how did they resolve the problem? Well, they resolved the problem not by telling us to use more antibiotics or telling us to improve our infection prevention measures. They told the chief executives of the hospital that their bonus would not be paid unless they sorted out the problem. So it was a financial solution. Hospitals had targets, MRSA targets, which they had to reduce. They had to mandatorily report MRSA bacteremias, the tip of the iceberg, and they told the chief executive he would be fined and he wouldn't get his bonus unless he sorted out the problem. Well, it worked. Yeah, so financial incentives are very effective. So we no longer really see problems like this. Now, here's an elderly lady who's come into hospital with to have her diabetes and her heart failure corrected. But she's had a peripheral line put in, which has got colonized initially. So colonization of skin is that primary step before you get infection. The MRSA was sitting there at her peripheral line site, has multiplied locally, caused this severe soft tissue infection at the back of her hand, and she is bacteremic as well. So having come in with one problem, she's ended up in hospital with a life-threatening condition that's entirely preventable. Well, I think the measures that we brought in addition to antimicrobial stewardship, but infection prevention measures have helped resolve these issues, not completely, but to a significant extent. But we're also now seeing strains of resistant bacteria in the community. So in North America, the commonest cause of skin and soft tissue infection is MRSA. We don't see that so much in Europe, but clones of MRSA have evolved by antibiotic selection around the globe, and they are transmitted by all of us in our travels. So in the staphylococcal reference unit in Colindale, in London, all these strains have been gathered, and we found that we get multiple strains brought into the UK which have very variable antimicrobial susceptibility. It's very hard to predict what to treat them with the old antibiotics. Similarly, we're not great at assessing the severity of skin and soft tissue infection in many of our patients. And when we say skin and soft tissue infection, it can be everything from a colonized leg ulcer to overwhelming and life-threatening necrotizing fasciitis. And there's a huge spectrum of severity. And all these different conditions need different forms of treatment. And here's just an example showing both these patients are infected, they're separate patients, but it shows the spectrum of severity of illness. And in the top left-hand corner, we've got a localized abscess that can be drained and probably treated if it needs topical antimicrobials at all with topical agents, but it almost certainly does not need systemic agents. Whereas the patient in the bottom right-hand corner is critically unwell. She's going to need surgery. She's going to need antibiotics, she's going to need other interventions like intravenous immunoglobulin and organ support as well in critical care to save her life. So, the range of treatment is very wide. If we're talking about cellulitis, which is a very common condition that we see in hospitals, well, here the infection is too deep to manage with any topical antimicrobials. You're not going to have a topical antimicrobial that's going to penetrate and control that infection. And the infection is spreading along the planes of the skin and soft tissue as well. So these patients need systemic antibiotics, usually intravenous antibiotics, and often control of their sepsis, but can then go on to oral antibiotics at a later stage. At the other end of the spectrum, I think we've heard already in this symposium how often antibiotics are overused for skin and soft tissue lesions that are not infected at all. It's really important not to treat the lab report, but to treat the patient. And unfortunately, a lot of antibiotic use is used on the basis of a laboratory report coming back saying there is an organism with an antimicrobial susceptibility. We need to educate our colleagues to stop doing that, because that is the primary reason for selection pressure of resistance. So topical antimicrobials, I think, have a really useful role. And this is just an example, again, showing Sergi honey that Vanilla presented just now, of a patient who, would you have treated this patient with systemic antibiotics? He was a 77-year-old chap with peripheral vascular disease on the ward, large ischemic ulcers of his lower leg, which weren't healing. You can see in the top photograph, he's got some redness. So, of course, that's one of the signs of spreading infection. And there's a big biofilm there. It's heavily colonized. And this chap, by the time we got to see him, had several courses of different antibiotics because the lesion wasn't healing, intravenous antibiotics. And when the superficial lesion was swabbed, it was growing virtually every multi-resistant organism that we were aware of in our institution. So it had MRSA, it had vancomycin-resistant enterococci, it had coliforms, a variety of species of various susceptibility, and it had Pseudomonas aeruginosa. And they have been selected out by the 2 or 3 weeks of continuous different antimicrobials that he'd received to no effect. So this case was a prime case for topical management of the patient. Now, we can argue whether he needs any antimicrobials at all. I think he probably does, because of this huge bioburden in the lesion that, in my view, needs to be reduced to help that lesion heal. He's got poor blood flow, so that's another thing not in his favour. He was treated with topical Sergi honey, and you can see in the middle photograph, which was at 4 days, the Pseudomonas has changed colour. It's now sort of fluorescing green as the Pseudomonases are attacked by the antimicrobial effect of Sergi honey and are producing more of this pyocyanin pigment. But by day 10, in the bottom photograph, the lesion is looking clear. It's not sterile. We're never going to get that sterile. And if that was swabbed, many of those organisms were still there, but they were there in much lower concentrations and allowed this chap to at least start to heal. Another common reason for overuse of antibiotics is red legs, and many of you will have come across that. Many of our inexperienced colleagues see bilateral red legs and thinks, oh my goodness, they've got bilateral cellulitis, we better start them on systemic antibiotics. And of course, it's actually very rare to get bilateral cellulitis in that sort of clinical pattern. And the commonest reason for this, of course, is varicose eczema, which may be compounded by some of the topical agents that are put on the patient. So what are the advantages of topical treatment as opposed to systemic? Well, you can avoid the enzymatic degradation in the gastrointestinal tract of oral agents. You can avoid the discomfort and cost of IV administration. You can avoid systemic effects and systemic toxicity. And possibly most importantly, you can avoid the selective pressure on the normal flora of the skin and the gut. That the microbial biome seems to be becoming increasingly important as a measure of health. And if we can avoid disrupting that, I think that's a good thing. Of course, if you're using topical antibiotics or antimicrobials, you can achieve a very high local concentration as well. There are some disadvantages. There's very poor absorption, so you can only use it on very superficial lesions. You may get contact dermatitis and some degree of cytotoxicity, and certainly some of the chemical antimicrobials are cytotoxic as well. But again, it's my view as an infection doctor that it's quite useful to have a range of diverse prescribing in all these areas to help minimize selection pressure. If one's treating actual superficial infections, what are the aims of treatment? Well, you want the infection to resolve, but certainly in terms of impetigo, and this paper refers particularly to that, so very superficial staph or streptococcal infection of the epidermis, you want to resolve the pain and irritation caused by these lesions and the unsightly appearance, particularly when it appears on the face, but also to have an infection prevention role, to prevent transmission to other people and prevent recurrence in that patient. What types of topical treatment are there? Many of you will be familiar with most of these different categories, but there's a whole range of natural agents which have variable antimicrobial activity, everything from tea tree to other plant alkaloids, to manuka honey and other sorts of honey as well. Then there are processed natural products like Sergi honey, which goes through a process to make it more antimicrobial, but it still retains the products of the natural product. There are heavy metal compounds compounds, many of which are no longer recommended because of their toxicity, but of course we still use a lot of silver products. There are synthetic chemicals, hydrogen peroxide, acetic acid we've heard about, iodine, chlorhexidine. And then there are topical antibiotics. A whole range of those are used commonly around the world in many situations. Mupirocin, clindamycin, polymyxin, neomycin, fusidic acid. And then there are topical antifungals for antifungal treatment as well. Where might they be useful? Well, here we've got classical superficial skin infections. We've got impetigo, and in the top left-hand corner, we've got quite extensive impetigo, and in that situation, you're probably going to want to go for a systemic antibiotic. But in all the other cases, which are quite localized, you may well get away with topical antimicrobial activity to help those things resolve. And the little abscess, of course, just needs draining with or without some topical antimicrobial as well, but not systemic antibiotics. So what have we got available in terms of the antibiotics? Well, we've got mupirocin, commonly used to reduce MRSA colonization. And the attraction of mupirocin is that it's unrelated to any systemic antibiotics that we use. It's been used in therapeutic treatment in these guidelines, these Australian guidelines for treating, again, impetigo, along with antiseptics to reduce crust formation and to break down the inflamed areas. But oral treatments tend to be needed when there's more widespread infection. It's been used in treatment of folliculitis as well, but I'm not sure that it's that effective in that because, of course, with folliculitis, the infection is deeper, more contained, and you're not going to get the penetration of mupirocin that you would with either drainage or with systemic antibiotics. It's been used in infected atopic dermatitis as well, and it's been suggested that the bacterial bioburden there makes disease, it takes longer to heal if you've got a heavily bacterially colonized atopic dermatitis. So topical treatment, again, with antimicrobials there may be helpful. Fusidic acid is widely used by our dermatology colleagues, and we in the infection world tut at this because we can guarantee that when we see a patient with a fusidin-resistant Staph Aureus, it's almost certainly come from the dermatology clinic. So this is an agent which I think we shouldn't be using topically because it's an agent that is used systemically. It's useful in deep-seated staphylococcal infection, and all we're doing when we use it widely topically is to select out resistance. There's some new antibiotics which I have no clinical experience in, but here's another one which is solely used for topical treatment, retapamulin, and that's had efficacy in treating superficial staph infections and in decolonization as well. So antibiotics, really the message with antibiotics for topical use is don't use them if they are used systemically, and use them sparingly for conditions where they're going to have a real effect. So in other words, localized superficial infections. Where are antiseptics used? Well, they're used widely. They're used for again, reducing superficial bioburden in normal skin prior to surgical procedures. They're used in reducing decolonization, and they're used in reducing the bacterial bioburden in open lesions. And I think many of these have a role to play in that. One of the disadvantages of antiseptics is that some of these chemical agents may be cytotoxic, so they may reduce the healing of the lesion. But again, there's lots and lots of data to support antiseptics in all sorts of situations, from decolonization to reducing bioburden. Many of these are also combined with some sort of alcoholic preparation as well. So there's alcoholic chlorhexidine, alcoholic povidone iodine, and that increases the bactericidal rate of killing. Natural products such as tea tree oil have been used, and this particular study is a rather negative study because they use this to see if tea tree washes could help reduce the acquisition of MRSA colonization on an ITU. But in this particular study, there was no difference between washing the patient with Johnson's baby oil or tea tree oil in terms of acquisition of MRSA. But there are many studies which also show a positive effect of tea tree and other plant alkaloid products in reducing bacterial colonization in open wounds, but also in decolonization. And so there is a role, I think, for these to be played as well in reducing bacterial bioburden. Surgery honey we've already heard a lot about. It seems in this study which we did in our laboratory, where we showed it was highly antimicrobial against gram-positives, gram-negatives, including all multi-drug resistant strains, and it has some antifungal and antiviral activity as well. And you can see here in terms of the zones of inhibition size compared with Manuka 25 that it appears to be more antimicrobial. Now, whether that's a good thing or not is for you to decide, but in terms of reducing bacterial bioburden, it is very effective at doing that. Time to finish. I'll flick through. Sorry to have gone on so long, Chairman. But we've used it clinically in quite a few situations. So in mild superficial wound infections as a topical agent, in clearing in clearing the inflammation and in clearing MRSA, in primary care clearing along with systemic antibiotics, colonization and MRSA from sort of folliculitis in the axilla. We've used it in where there's prosthetic devices, so in long oncology lines, in colonized with gram-negative organisms, surgery honey has been effective at clearing that. And in complex surgical wounds, which are heavily colonized with multi-drug resistant gram-negatives, it reduces bioburden and I think helps with healing as well. Another superficial lesion, this slide just shows the disadvantages of multiple piercings in the ear because it can result in impetigo. So I think I will stop there. But in summary, we need to avoid antibiotics where there's no subcutaneous spread of bacterial infection. I think we've kind of come to the conclusion that informed expert opinion is the best mode of detecting whether there really is infection in that grey area in the middle. We know when there is an infection. We know when there is severe infection. In that grey area, informed expert opinion is probably the best measure. And topical treatment is effective for localized superficial skin infection. Colonization and biofilm reduction probably help healing, and topical treatment can reduce transmission, persistence and recurrence. So use topical agents that are not used systemically, such as mupirocin and surgery honey. Thank you. And I apologize for going on to that.
Okay, thanks, Matt. Just while Andrew, if you could load up, we'll take one burning question, just because we're just a little bit past the allocated time. Any questions?
I wanted to make one quick
Matt,
comment about your slide about the tea tree oil versus Johnson's baby wash. There are two trials that have not been published comparing topical antimicrobial peptides against placebo for impetigo, large studies in poor populations in the Caribbean. Neither's been published, but both showed that there was no difference between the two. And the reason is they gave them soap and water, which they didn't normally have. Soap and water works for impetigo.
Okay. Thank you. Thank you very much. Thank you, Matt.